medicine, the acid-base imbalance, the acidosis and alkalosis. Now, first, we will shortly discuss about the water and electrolyte. Now, water is the solvent of the life. We can say the water is the life. The function of the water is provides the aqueous medium to the organisms, and water directly participates as a reactant in several metabolic reactions. It is a vehicle for transport of the solutes. It is associated with regulation of body temperature. Distribution of water, there is about the human body is made up of 60% of the water. There is 42 liters of water in a normal built human body, and this is distributed into intracellular, that is 28 liter, and extracellular, that is 14 liter. If we see the water turnover and balance, the water intake is mainly supplied by the exogenous and the endogenous water. The exogenous water is the ingested water. The person, whatever the water is drink by the person, water content of the solid foods, and it constitutes the exogenous source of the water. The ingestion of water is mainly controlled by the thirst center. We already know it is in the hypothalamus, the posterolateral nucleus of the hypothalamus. The endogenous water is the metabolic water produced by the different process. It is the endogenous water. Around 300 to 350 ml of the water is derived from oxidation of the foodstuffs. So water output, the elimination of water from the body occurs through urine, skin, lungs and feces. Mainly urine and perspiration. Lungs, because all the air that is exhaled is having the humidity, and feces. The electrolyte balance is also very important. Electrolytes are the compounds which readily dissociated in solution and exist as ions, like positive and negative charge particles, what we call the anions and cations. The electrolytes are well distributed in the body fluids in order to maintain the osmotic equilibrium and water balance. If we see the extracellular fluid component, then the value of cation and anions is equal. Sodium is 142, potassium is 5, calcium is 5, magnesium is 3, making total of 155. And anions, chloride 103, bicarb 27, phosphate 2, sulfate 1, protein 16, organic acid 6, making it 155. So 155 equilibrium is there in the extracellular fluid. When we talk about the intracellular fluid, there is a potassium dominance. In the extracellular fluid, there is a sodium dominance. In intracellular, there is potassium dominance. Potassium is 150, sodium is 10, magnesium is 40, calcium is 2, making it 202. And anions, phosphate 140, bicarb 10, chloride 2, sulfate 5, proteins 40, organic acid 5, making it 202. So here also the equilibrium is achieved. Sodium is the principal extracellular cation and potassium is the principal intracellular cation. Osmolarity and osmolality, these two are different terms. The osmolarity means the number of moles per liter of solution, and osmolality means the number of moles per kilogram of the solvent. So this is liter and this is kilogram. Now regulation of the electrolyte balance, I don't go into the detail because a different video will be there to understand the hyponatremia, hypokalemia and hyperkalemia. The electrolyte and water balance are regulated together. Kidney plays a very important and major role. There is also a role of hormone, which is aldosterone, and atrial natriuretic peptide. Aldosterone is a mineralocorticoid which is produced by the adrenal cortex. The aldosterone increases the sodium reabsorption by the renal tubules at the expense of potassium and hydrogen loss. The net effect is the retention of water and sodium into the body. The antidiuretic hormone, it increases the plasma osmolality because it is antidiuresis. It reduces the diuresis. Therefore, it increases the plasma osmolality and stimulates the hypothalamus to release the ADH. Whenever there is increase in the plasma osmolality, the hypothalamus is stimulated to secrete the ADH hormone. ADH will do antidiuresis. There will be less water in the urine, more water in the plasma, so the plasma osmolality will fall. ADH increases the water reabsorption by the renal tubules, and that will reduce the plasma osmolality. The secretion of aldosterone is controlled by renin-angiotensin system. Now, whenever there is a decrease in the blood pressure, it is sensed by the juxtaglomerular cells in the nephron, and which secretes the renin. This renin converts angiotensinogen to angiotensin 1, and this angiotensin 1 is converted into angiotensin 2, which stimulates the release of the aldosterone. And aldosterone and ADH, they coordinate with each other to maintain the normal fluid and electrolyte balance. So they both work together. Sodium reabsorbs and happens, the water is reabsorbed, and this helps to maintain the normal fluid and electrolyte balance. Now, dehydration is characterized by water depletion in the body. It may be due to insufficient intake or excessive water loss, or both. Main causes of the dehydration occurs as a result of severe diarrhea, severe vomiting, excessive sweating like in the heat stroke, fluid loss in the burns, adenocortical dysfunction, kidney disease, and deficiency of the ADH, what we call the diabetes insipidus. Now we come to the main topic, the acid-base imbalance. First, we will discuss about the acid-base balance, how the beautiful acid-base equilibrium is maintained in our body. The acid is a substance whose dissociation in water releases the hydrogen ions. Whenever you get a H plus, when something is dissociated and you get the H plus, it is acid. Addition of acid into a solution increases the concentration of free hydrogen ion inside the solution, and it produces more acidic solution. And when the solution is more acidic, there is a fall in the pH. We all know the acidic solutions have low pH, the alkaline solutions have high pH. So suppose we take the example of HCl. HCl gets dissociated into H plus and Cl minus. So you get the H plus ion. The base is, a base releases the hydroxyl ion. In the acid there is a hydrogen ion. The base releases the hydroxyl or OH minus in aqueous solution and decreases the H plus concentration by binding with the free H plus. Whatever the free H plus is there, the OH combines with it and forms the water. H plus OH is H2O. This results in increase in the pH of the solution. As the alkaline solution is there, there will be rise in the pH. Now, for example, NaOH, it gets converted into Na plus OH minus. The OH plus accepts the H plus, results in the formation of H2O, that is water. Now, what is amphoteric substances? Some substances such as amino acids and proteins act as acids as well as bases according to the situation. These substances are referred to as amphoteric substances. Now, how the pH is maintained? The normal pH of the blood is 7.35 to 7.45 and neutral pH is 7. So, normal pH of the blood is little bit slightly alkaline. It is 7.35 to 7.45. The body has developed three lines of defense to regulate the body's acid-base balance. There are three mechanisms, three defense systems. The blood buffers, the respiratory mechanism, the renal mechanism, out of three, the blood buffers are the buffers defined as solution of weak acid and its salt with a strong base. The buffer resists the change in the pH of the blood by the addition of acid or alkali, and the buffering capacity is dependent on the absolute concentration of salt and acid. The buffer cannot remove the hydrogen ion from the body, but it temporarily acts as a shock absorber to reduce the free H plus ion. Now this cannot remove, but it just combines with the H plus and try to remove to a certain extent for a certain amount of time. The blood contains three buffer systems: the bicarbonate buffer, the phosphate buffer, the protein buffer. Now out of these three, the bicarbonate buffer system is sodium bicarbonate and carbonic acid, NaHCO3 and H2CO3 is the most predominant buffer system of the extracellular fluid, that is plasma. The carbonic acid dissociates into hydrogen and bicarbonate ion. We all know H2CO3 converts into H plus and HCO3 minus. Now, by the law of mass action, Ka is equal to H plus into HCO3 minus divided by H2CO3. Ka is the dissociation constant of H2CO3. I don't go into the detail of this because we all have learned it into our biochemistry classes. The equation may be rewritten as follows: H plus is equal to Ka upon H2CO3 divided by HCO3. Now, if we take the pH as log 1 upon H plus, by taking this, the reciprocal logarithm will be log 1 upon H plus equal to log 1 upon Ka plus log HCO3 divided by H2CO3. So, log 1 Ka is equal to pK, and the equation 3 may now be written as pH is equal to pK plus log HCO3 upon H2CO3. The above equation is referred as Henderson-Hasselbalch equation for any buffer. So pH is equal to pKa plus log base upon acid. This is called the Hasselbalch-Henderson equation or Henderson-Hasselbalch equation. Now, by this, now let us see the blood pH and ratio of bicarbonate and H2CO3. The plasma bicarbonate concentration is around 24 millimole per liter. Range is 22 to 26, but let us assume it is 24 millimole per liter. Carbonic acid is a solution of CO2 in the water. H2O plus CO2 is H2CO3, that is carbonic acid. Its concentration is given by the product of PCO2, that is arterial partial pressure of CO2, that is 40 millimeter, and the solubility constant of CO2, that is 0.03. So when you multiply the 40 into 0.03, you get the concentration of this product of PCO2 and solubility constant. So H2CO3 is equal to 40 into 0.03, that is 1.2 millimole per liter. Now the Henderson-Hasselbalch equation for the bicarbonate buffer is pH is equal to pK plus log bicarb divided by carbonic acid. Now we put this value, that is pH 7.4, pKa for H2CO3 is 6.1, HCO3 is 24 and H2CO3 is 1.2. So 7.4 is equal to 6.1 log 24 divided by 1.2, that is 6.1 plus log 20, that is 6.1 plus 1.3, that is 7.4. Left side equal to right side. The blood pH 7.4, the ratio of bicarb to carbonic acid 20:1. As we saw here, the bicarb is 24 and H2CO3 is 1.2. So the ratio is 20:1, 20 times more. This is referred to as alkali reserve. The amount of bicarbonate is more than the carbonic acid. It is almost 20 times more, and this is called the alkali reserve. Now the phosphate buffer system. The sodium dihydrogenate phosphate and disodium hydrogen phosphate, that is NaH2PO4 and Na2HPO4, constitute the phosphate buffer. It is mostly intracellular. Now the bicarb is mainly extracellular. The phosphate, that is NaH2PO4 and Na2HPO4, are the intracellular buffers. The protein buffer system. The plasma proteins, that is hemoglobin, constitute the main protein buffer. The buffering capacity of protein is dependent on the pK of ionizable group of amino acids. The imidazole group of histidine, pK 6.7, that means at pH 6.7, half of the acid is converted into H plus ion, is the most effective contributor of protein buffer. Now we come to the respiratory mechanism for pH regulation. The respiratory system provides a rapid mechanism for the maintenance of acid-base balance. This is achieved by regulation of the concentration of carbonic acid in the blood. The large volume of CO2 is produced by the metabolic activity, and this CO2 is washed out by the expiration. All of this CO2 is eliminated from the body by which happens because of the expired air via the lungs. We all know the carbonic acid H2CO3 is converted by carbonic anhydrase into CO2 and H2O. A patient who has taken OP poisoning, the carbonic anhydrase is blocked, and therefore this conversion is blocked, and the patient goes into all the complications. Now, the rate of respiration is controlled by a respiratory center in the medulla, and this respiratory center is controlled by two things. It is highly sensitive to the change in the pH. Whenever there is a decrease in the blood pH, it causes the hyperventilation, because when in hyperventilation to blow up CO2, reducing the H2CO3. So whenever there is a drop in the pH, that means the blood is acidic. At that time, the body tries to wash out the carbonic acid, and that is done by washing out of the CO2. That is done by the hyperventilation. This center is also sensitive to hypoxia as well as the hypercapnia. If the PO2 is reduced, hypoxia is there, there will be stimulation of the center. If the PCO2 is more than 42, again the center will be stimulated. The H ions are eliminated as H2O. The respiratory control of blood pH is rapid but only a short-term regulatory process. This is a rapid process, the respiratory process, but it is a short-term. There is a respiratory fatigue. The patient will not go up with all this hyperventilation, and this cannot proceed for a long time. Now we talk about the hemoglobin as a buffer. Hemoglobin binds to H plus ions and helps to transport CO2 as HCO3 with a minimum change in the pH. In the lungs, the hemoglobin combines with O2. H plus ions are removed, which combine with HCO3 to form the H2CO3, and it dissociates to release CO2, which is exhaled in the blood. Generation of the bicarbonate by RBC. Due to lack of aerobic metabolic pathways, the RBC produce very little CO2. The plasma CO2 diffuses into RBC along the concentration gradient. The CO2 is very less in the RBC. Whenever the plasma CO2 is high, it goes into the RBC via concentration gradient. It combines with water to form the H2CO3 by carbonic anhydrase. We saw previously that H2O plus CO2 in presence of carbonic anhydrase will produce H2CO3. And this H2CO3 now dissociate to produce the H plus and HCO3 minus. The H plus ions are buffered by the hemoglobin. This hemoglobin will combine with the H plus. This we'll understand simply in the figure which follows after this slide. As the concentration of the HCO3 increase in the RBC, it diffuses into the plasma along with the concentration gradient. In exchange for the chloride, this is called chloride shift that maintains the electrical neutrality. This is called chloride shift, and it helps to generate the HCO3. This description is a bit confusing, but let's make it simple by this figure. The generation of bicarbonate by erythrocytes. Whenever the erythrocyte has CO2 and H2O, in presence of the carbonic anhydrase, it is converted into H2CO3. This H2CO3 dissociates into H plus and HCO3 minus. The HCO3 minus enters inside the plasma by concentration gradient. The H plus combines with the hemoglobin and is taken up by the hemoglobin. Now, the loss of bicarbonate is compensated by loss of chloride. So, there is the maintenance of the electrical potential inside the RBC. This is called a chloride shift. So all process starts with the entry of CO2 inside the RBC by concentration gradient, and the bicarbonate also is pushed out of the RBC into the plasma by concentration gradient, and chloride enters inside the RBC. Chloride shift, bicarb is retained, and H combines with the hemoglobin. This is a hemoglobin buffer system. Now the renal mechanism for pH regulation. The kidney plays a very important role in the regulation of the pH. Normal urine pH is acidic. Remember this. Normal urine pH is acidic because there is too much of H plus ion inside it. It is around 6. The pH of urine varies from 4.5 to 9.8. This can be acidic, severe acidic or severe alkaline, but mainly it is around 6 and it's acidic. The renal regulation of the pH, again we will discuss it in few slides, and then we will see a very simple figure which will explain everything. The excretion of H plus ions, the bicarbonate will be retained. The excretion of titratable acids, we will see what is titratable acid, and excretion of the ammonium, that is NH4 plus ions. The excretion of the H plus ions. Kidney is the only route through which the H plus ions can be eliminated from the body. The hydrogen excretion occurs in the proximal convoluted tubules and is coupled with the generation of bicarb. As we saw previously, H plus HCO3 from the carbonic acid, H plus goes into the urine, HCO3, bicarbonate is retained. The carbonic anhydrase catalyzes the production of H2CO3 from CO2 and H2O in the renal tubular cells. Remember, the carbonic anhydrase in the kidney is present in the tubular cells, which converts the CO2 and H2O into H2CO3. Now this H2CO3 dissociates into H plus HCO3 minus. H plus ions are secreted into the tubular lumen in exchange of the sodium. So sodium in association with the bicarb is reabsorbed into the blood because these two are important. It's reabsorbed, potassium is lost in the urine. Effective mechanism to eliminate acid from the body with a simultaneous generation of bicarb. So acid is lost, bicarb is retained. H plus combines with non-carbonate base and is excreted. So again, we see this figure. The CO2 plus H2O in presence of carbonic anhydrase makes the H2CO3 in the renal tubular cell. This dissociated to H plus, HCO3 minus. HCO3 minus goes to the blood and it is retained. The H plus goes into the tubular lumen. It binds with some base, and this hydrogen base combination is excreted The tubular lumen sodium, it entered inside the renal tubular cell, it is reabsorbed inside the blood. So you gain the sodium, you gain the bicarb, you lost the hydrogen. So the balance of acid and base, we saw previously there is a 20 times more bicarb is because of this beautiful mechanism. Now reabsorption of the bicarbonate, the mechanism responsible to conserve blood bicarbonate with simultaneous excretion of the H plus ions. Bicarbonate freely diffuses from plasma into the tubular lumen. This bicarbonate combines with H plus secreted by tubular cells to form the H2CO3. So this H2CO3 is then cleaved to form CO2 and H2. And the CO2 concentration builds up in the lumen. It diffuses into the tubular cells along the concentration gradient. The tubular cells CO2 again combines with H2O from the H2CO3. Now it is again converted into H plus HCO3 minus. H plus is secreted into lumen in exchange for the sodium. The HCO3 is reabsorbed into the plasma with sodium. The reabsorption of bicarb is a cyclic process with the net excretion of hydrogen and generation of new bicarb. This mechanism helps to maintain the steady state and will not be effective for the elimination for hydrogen or generation of new bicarb. So if we see this whole process in a simple figure, H2O plus CO2 in the renal tubular cell, in the tubular lumen, this H2 and CO2 in the presence of the carbonic anhydrase is converted to H2CO3. Now in the tubular lumen, what happens? Whenever the bicarb enters inside, there is hydrogen ion which comes out from the linear tubular cell. This two combines to form the H2CO3. This H2CO3 is again converted into CO2 and H2O. This CO2 enters inside the linear tubular cell by the concentration gradient, combines with the H2O to form the H2CO3 in the presence of carbonic anhydrase. This is again dissociated into H plus and HCO3 minus. H plus is again entering into the tubular lumen because it is utilized to combine with the HCO3, and this bicarb is retained. You see the bicarb is retained, but the hydrogen enters for the again this cycle. So more and more bicarb you are retaining and you are losing more and more hydrogen. So we start this figure from here. Bicarb enters from into the tubular lumen. The hydrogen enters from the renal tubular cell. They both combine to form the H2CO3, which is converted into CO2 and H2O. The CO2 by the concentration gradient enters inside the renal tubular cell, combines with the H2O in presence of the carbonic anhydrase to form the carbonic acid, dissociate into HCO3 and H plus. HCO3 is retained, sodium is also retained, and hydrogen is again pushed into this process. Now the excretion of titrable acid. Titrable acidity is a measure of acid excreted into urine by the kidney. Whatever acid is excreted is called the titrable acid. Titrable acidity refers to the number of milliliters of N10NaOH required to titrate 1 liter of urine to near normal pH. Titrable acidity reflects the hydrogen ion excreted into the urine. So term titrable acid is nothing but it is the acidity of the urine and the hydrogen ion excreted into the urine. The H plus ions are secreted into the tubular lumen in exchange of sodium. We have seen this. This sodium is obtained from the base disodium hydrogen phosphate. As we saw in previously, the Na2HPA4 and NaH2PO4, the intracellular buffers, they comes into play here. Now this Na2HPO4, it combines with H and donates the Na to make NaH2PO4 and that is major quantity of titrable acid in the urine which is excreted. The tubular fluid moves down the renal tubules, more and more hydrogen ions are added, resulting into the acidification of the urine. As the fluid moves down, more and more hydrogen comes inside. It causes to fall of the pH to as low as 4.5. Because of all this hydrogen ions richness, the pH is as low as 4.5 and it is acidic. Now let's understand this with a simple figure. This is tubular lumen, this is intracellular buffer, the Na2HPA4, which is cleaved to Na plus and NaHPO4. Now the H2 and CO2, carbonic anhydrase, H2CO3, Now it is dissociated into H plus and HCO3 minus. HCO3 minus enters inside the blood and it is retained. The H plus enters inside the tubular lumen, combines with this NaHPO4, forms the NaH2PO4 and it is excreted. This is how the bicarb is retained, hydrogen is lost. Bicarb is retained, hydrogen is lost. And whenever the bicarb is retained, sodium is also retained. This sodium which dissociates from Na2HPO4, that is Na plus NaHPO4, enters inside the renal tubular cell and then it goes reabsorbed into the blood. This is how this beautiful buffer system works. The excretion of ammonium ions. The H plus ion combines with ammonia to form the NH4, the ammonium ion. The renal tubular cells deaminate glutamine and glutamate and NH3 by the action of enzyme called glutaminase. This liberated NH3 diffuses into the tubular lumen where it combines with the H plus to form the NH4, the ammonium ions. The ammonium ions cannot diffuse back and they are excreted into the urine. Let's see it with this figure. This is the renal tubular cell. The glutamine is converted into glutamate and during this process the ammonia is formed. The ammonia enters inside the tubular lumen. This glutamate this glutamate is now also there is another process happening, that is H2O plus CO2, again the same process in the presence of the carbonic anhydrase is converted into the carbonic acid which dissociates into H plus HCO3 minus. Now this H plus enters inside the tubular lumen. This NH3 and H plus combines to form the NH4 which is excreted. The HCO3 enters inside the blood and it is retained. The sodium in the same process from the tubular lumen enters inside the lunar tubular cell and then in the blood. So glutamate in this process NH3 is produced. NH3 combines with the H plus which is obtained from the renal tubular cell from H to CO3. This H is lost as NH4 plus and bicarb is retained. So again hydrogen is lost, bicarb is retained, sodium is retained. So disorders of the acid-base balance. The acid-base disorders are mainly of two types: acidosis, that is more acid, decline in pH, and alkalosis. The acidosis can again be divided into two types: the metabolic acidosis due to decrease in the bicarbonate, or respiratory acidosis due to increase in the carbonic acid. So either the fall in the bicarbonate by some metabolic causes or a rise in the CO2, in turn increasing the carbonic acid, causing the acidosis, the metabolic acidosis or respiratory acidosis. Alkalosis is more alkali, rise in the pH. Another two causes: metabolic alkalosis due to rise in the bicarbonate, or respiratory alkalosis because of the fall in carbonic acid. Anything which wash out the CO2, anything which reduces the carbonic acid will produce the respiratory alkalosis. The causes of the acid-base disorders, we will see the detailed causes in the last slide. But metabolic acidosis, mainly diabetic ketoacidosis, lactic acidosis, renal tubular acidosis, renal failures. The causes of the respiratory acidosis: severe asthma, any depression of the respiratory center, cardiac arrest will cause the respiratory acidosis because the CO2 narcosis will happen, CO2 will rise and in turn the carbonic acid H2CO3 will rise. The metabolic alkalosis, main causes are vomiting because you are losing the too much of HCl, hypokalemia. Respiratory alkalosis mainly because of the hyperventilation, because whenever the patient does the hyperventilation, the CO2 is washed out, there is fall in the carbonic acid and there will be respiratory alkalosis or severe anemia. The anion gap, the total concentrations of cations and anion is equal in the body. The concentration of positive ions and negative ions is equal. It is required to maintain the electrical neutrality. The commonly measured electrolytes are sodium and potassium as cations, and chloride and bicarbs are anions. Sodium and potassium together constitute about 95% of the plasma cations, but same is not true about the anions. In anions, the chloride and bicarb, they constitute 80% of the plasma anions and 20% of the rest are called these are because of the proteins, phosphates, sulfates, urates and organic. So in some acidosis, this 20% is high and therefore we call it a high anion gap acidosis. So anion gap is defined as the difference between the total concentration of the measured cations and that of the measured anions. Na plus sodium and potassium and chloride and bicarb are mostly equal, but the gap between the two we call the anion gap. The anion gap in fact represents the unmeasured anions in the plasma. So anion gap is this 20%. We are measuring this 80%. Whatever we are not measuring is the anion gap, which may be calculated as follows by substituting the normal concentration of the electrolyte. So sodium plus potassium, it is 136 plus 4. Chloride plus bicarb is 100 plus 25 plus this anion gap. So normal anion gap is 15. That is 140 minus 125. Normal anion gap is 15. So in few conditions, in few metabolic acidosis, this is very high, and that we call the high anion gap metabolic acidosis. The metabolic acidosis is reduction in the bicarbonate, which leads to a fall in the pH. This is due to excessive production of the organic acids, and that uses the bicarbonate, that combines with the bicarbonate to deplete the alkali reserve. As we saw previously, there is a good amount of the alkali reserve, and when this alkali reserve is totally utilized, then the pH is not maintained, the pH falls, and the metabolic acidosis happens. So it is commonly seen in the DM. The diabetic ketoacidosis is one of the most common cause of the metabolic acidosis. The respiratory acidosis, the primary defect is because of the retention of the CO2, what we call the CO2 narcosis. Because of the respiratory depression, the patient is not maintaining the ventilation properly. There will be increase in the CO2, increase in the H2CO3. Causes of the respiratory acidosis are depression of the respiratory center, pulmonary disorders, breathing air with high content of the CO2. All the gas poisoning, all the workers who are working in the underground sewage, they can get this CO2 narcosis and respiratory acidosis. Metabolic alkalosis is due to increase in the bicarb concentration inside the serum. Occur due to excessive vomiting, because in the vomiting you are losing too much of the HCl, or excessive intake of sodium bicarbonate for therapeutic purposes. Few patients, they have a tendency to drink too much of soda, too much of sodium bicarb. This can land up the patient into metabolic alkalosis. Respiratory mechanism initiates compensation by hyperventilation. There is suppression of the respiratory center so that the CO2 is retained and carbonic acid is retained, so that the normal pH is achieved. Then there is a renal mechanism which excretes more bicarbonate and retain hydrogen. We saw all the renal mechanism, how the hydrogen is lost and bicarb is retained. In this condition, whenever there is metabolic alkalosis, this process is reversed so that the bicarb is lost more and there is retention of hydrogen ion. The respiratory alkalosis, this is due to decrease in the H2CO3 concentration. Prolonged hyperventilation. Suppose patient is having severe anxiety and he is having hyperventilation syndrome. This leads to CO2 washout. There will be fall in the CO2, fall in the carbonic acid, and rise in the pH, causing the respiratory alkalosis. Remember one thing, whenever there is a respiratory alkalosis, there is reduction in the ionized calcium. Though the serum calcium level is normal, the ionized calcium will fall, and therefore there are all the chances that a patient with hyperventilation can present to you or can land up to you with tetany, carpopedal spasm. The renal mechanism tries to compensate by increasing the urinary excretion of the bicarb. Again, same thing, the hydrogen is retained and bicarb is lost. The acid-base disorders and potassium, there is a relation. Plasma potassium concentration normally is 3.5 to 5, is very important, and it affects the contractility of the heart. Hyperkalemia and hypokalemia, both are life-threatening. The potassium and diabetic ketoacidosis, the insulin increases the potassium uptake by the cells. The intracellular shift of potassium is facilitated by the insulin. The patient of severe uncontrolled diabetes with the metabolic acidosis is usually hypokalemic. When such a patient is given insulin, the more potassium goes inside the cell and hypokalemia becomes worse. Further depleted, hypokalemia may affect heart functioning and is life-threatening. Potassium and alkalosis. The low plasma concentration of the potassium, hyperkalemia, leads to increased excretion of the hydrogen ions. This is as a compensatory. We want to retain the potassium. The more hydrogen is lost, and then it can cause the metabolic alkalosis. Conversely, the metabolic alkalosis itself is associated with increased renal excretion of the potassium. So the respiratory acidosis treatment, very few slides I will touch about the treatment. The treatment is restore the ventilation. If the patient is having too much of the acidosis, then you might have to put the patient on the ventilatory support. I will lactate, soda bicarb, and treat the underlying dysfunction cause. If the patient is having CO2 narcosis because of the CO2 poisoning, then you have to treat the cause. If the patient is having respiratory depression because of some disease, you have to treat that cause. Respiratory alkalosis, you treat the underlying cause, reduce ventilation. If the patient is having anxiety, hyperventilation syndrome, reassure the patient. Breathe into a paper bag. If the patient is having too much of anxiety and doing hyperventilation, put a paper bag over the patient's mouth and nose. So what happens? Patient breathe inside the bag. So more and more CO2 is there in the bag, and then the patient breathes the CO2 more. So it will raise the CO2 and the H2CO3 level and will reduce the alkalosis. IV chloride containing solution, because chloride ions replace the lost bicarbonate ions. Metabolic acidosis treatment is IV lactate, soda bicarb, and treat the underlying cause. Suppose the patient is having decay, whatever bicarb you give, it is not going to give any benefit. Treat the cause. Metabolic alkalosis treatment is electrolyte to replace those lost. Ascorbic acid, this can give some acidification of the serum. IV chloride containing solution and treat the underlying cause. Now, the causes of acid-base balance, just remember by these numerals. Metabolic acidosis with anion gap, mud pillars, methanol, uremia, decay or alcoholic ketoacidosis, paraldehyde, isoniazide, lactic acidosis, ethanol, renal failure, rhabdomyolysis, and salicylates. So, mud pillars. Metabolic acidosis with no normal gap is HERDUPS, hyperalimentation, acetazolamide, renal tubular acidosis, diarrhea, urethropelvic shunt, post-hypocapnia, spironolactone. Acute respiratory acidosis is anything causing the hypoventilation. CNS depression, airway obstruction, pulmonary edema, whatever is retaining the CO2, pneumonia, pneumothorax, in present area, the COVID-19 neuromuscular problems like myasthenia gravis, they all can retain CO2 and cause the respiratory acidosis. Metabolic alkalosis, clever the contraction, licorice, endocrine disease like Crohn's, Cushing's, Bartter's, vomiting, excess alkali, refeeding, post-hypercapnia, and diuretics. Respiratory alkalosis, CHEMS, CNS disease, hypocapnia, anxiety, mechanical ventilation, progesterone, salicylates, sepsis. This all you have to learn by the heart. But if you know the basics, then so many things will be clear in this. Now let us just recollect the normal values. pH 7.35 to 7.45, PCO2 is 35 to 45. Whenever it is more than 45, like 55, 62, 72, we call it CO2 narcosis. PO2 is around 80 to 100 millimeter of mercury. Potassium is 3.5 to 5 milliequivalent per liter. Sodium is 135 to 145. Chloride is 98 to 108. Bicarb is 22 to 26. Anion gap is 9 to 16. This looks complicated, but once you start treating patients in the critical care centers and you start ordering ABG, this will be your daily bread and butter, and you will never forget these values. Just last slide. If you just correlate this bicarb level, pH, and other things, this is respiratory acidosis when the pH is in the acidic range. The plasma bicarb is here, and this is metabolic alkalosis, this is metabolic acidosis, and this is respiratory alkalosis. That ends my this short presentation on acidosis and alkalosis. This is a big subject, but I tried to make it as simple as possible. If there are any queries, feel free to